Hello, I am Dr. Said, member of Department of General Surgery. This short video reviews current guidelines of management of anal fistula. Drainage of anorectal abscess results in cure for about 50% of patients. The remaining 50% develop a persistent fistula in ano. The majority of fistulas are cryptoglandular in origin. A complex, recurrent or non-healing fistula should raise the suspicion of one of these diagnoses. Patients with anal fistula present with persistent drainage from internal or external openings. An indurated tract is usually palpable, and Goodsall's rule can be used as a guideline in determining the location of the internal opening. Based on this rule, fistulas with an external opening anteriorly connect to the internal opening by a short radial tract, but fistulas with an external opening posteriorly track in a curvilinear fashion to the posterior midline. The exception for this rule is anterior external opening greater than 3 cm from the anal margin. Such fistula usually track to the posterior midline. Fistulas are categorized based on their relationship to the anal sphincter complex. The commonest one is an intersphincteric fistula, which tracks through the distal internal sphincter and intersphincteric space to an external opening near to the anal verge. A transphincteric fistula often results from an ischiorectal abscess and extends through both the internal and external sphincters. A suprasphincteric fistula originates in the intersphincteric plane and tracks up and around the entire external sphincter. An extrasphincteric fistula originates in the rectal wall and tracks around both sphincters to exit laterally, usually in the ischiorectal fossa. The goal of treatment of fistula in ano is eradication of sepsis without sacrificing continence. Because fistula tracts encircle variable amounts of the sphincter complex, surgical treatment is dictated by the location of the internal and external openings and the course of the fistula. Injection of hydrogen peroxide or dilute methylene blue may be helpful to identify internal opening, treated either by fistulotomy or by placement of seton. This is a commonly practiced approach. Fistulotomy is it's just opening the fistula's tract. Seton it is nothing but it is a drain placed through a fistula to maintain drainage and induce fibrosis. Setons are classified into two, cutting and non-cutting types of setons. The cutting type of setons, it consists of a suture or a rubber band that is placed through the fistula and tightened in the office. This tightening results in fibrosis and gradual division of the sphincter, thus eliminating the fistula while maintaining continuity of the sphincter. Non-cutting setons, it is a soft plastic drain placed in the fistula, maintain drainage. The fistula tract may subsequently be laid open with less risk of incontinence because scarring prevents retraction of the sphincter. Sphincteric fistula and low type of transphincteric fistula, that means which includes less than 30% of the sphincter muscle, approached with fistulotomy. But the high type of transphincteric fistula and suprasphincteric fistula, they need the placement of seton. The extrasphincteric fistula, which is the complex one, and in general the portion of the fistula outside the sphincter should be opened and drained.